ఫస్ట్ నేను మ్యూట్ చేసేసి
request all the faculties to rename the session so we can see when the question answer session we can identify easily. So normally we wait for 50 participants. So we can go ahead with the presentation now. So with this session today, as I repeatedly, in the initial session, I say that's a 4 year of NOEL. So good evening and welcome all of you, the faculties and delegates for this session today. After completing the neurology session, respiratory session, and initially we introduced one of the nutrition, mother's own milk importance, its importance and how to establish it. Now we move to a case presentation from the cardiac series. So with this presentation today is little bit modification of the presentation here, because last 4 sessions we went for different case presentation and we went for some faculty talk. Today there are 2 cases will be there. So Dr. Preeti from Jaipur Neo Clinic, she is going to present 2 cases today. So these 2 cases both are from the cardiac case only. So Dr. Preeti Chaudhary, the NNF fellow student, their trainee from Neo Clinic, is going to present 2 cases. The first case, I hope it is a preterm PDA management. And next week case will be again another cardiac case, which they will reveal through the presentation. And to the moderate the session, we got 2 esteemed faculty today. Dr. Fani Bhargavi, she is a pediatric cardiologist from Rainbow Children Hospital Cardiac Center. She is a renowned pediatric cardiologist with immense interest in teaching in the neonatal and pediatric cardiology. So she will guide throughout the session with the discussion, the cardiac some inputs. We will get how the cardiologist perspectives of a case when we discuss the cardiac case, how they look into the evaluation and the management time, what inputs actually when we ask them, we need them, their inputs, how they proceed with the case. That we learn from them. And simultaneously, the same Neo Clinic, along with Dr. Rohit Jain, Dr. Prerna Bhatt, she is there, the pediatric cardiologist. So both of them will give the cases, how the case, the diagnosis and management, how effectively they managed, and what are the challenges, discussion time, how we need their inputs. And to lead the discussion further, Dr. Sankalp Dudeja, he is a senior neonatology consultant from Cloud9, Gurgaon. So he is again a young enthusiastic academician among the neonatology field. So with this, all the faculty's input, I hope that today's learning session about the 2 important cardiac cases, a lot of learning is waiting for all the delegates and trainees. I request Dr. Preeti to start the session, the presentation, but any of the faculties, Dr. Rohit, Dr. Bhargavi, Dr. Sankalp, Dr. Prerna, any of the faculties, if you can, any inputs you want to give input before starting, what is our learning objectives will be there and how we should proceed. You can speak 1 minute, then we can proceed for presentation.
So I think one of the key learning objectives shall be what to expect from a pediatric cardiologist when we order an echo if we are suspecting PDA. Because ultimately the neonatologist and pediatric cardiologist work in conjunction, then we get the best result for the baby. Secondly, I think for the students, it would be very important to understand the basics and when to intervene and what to do. So I think by the end of this session, you should be able to basically clarify that what to do, when to do, and how to do. I think these should be the key learning objectives from my point of view.
I agree with Dr. Rohit. I think PDA objective sir has covered nicely. And as far as coarctation is concerned, I think the second case is coarctation. All of our fellows should be aware of we'll discuss the management, but you should be aware about picking up coarctation, and these children are often asymptomatic in the initial few days and are treated as normal newborns there in your ward. So how to pick up, what is the role of critical congenital heart disease screening, pulse oximetry screening, and other important clinical parameters that you should be doing. So picking up managing coarctation and picking up critical heart diseases before discharge is a very important aspect of normal newborn care. Yeah, so that.
Yes, sir, I agree. Actually, the harmonious role of neonatologist and pediatric cardiologist is very important in managing PDA because we tell numbers, but clinical correlation is very important in managing mainly preterm PDAs. Second thing, like identification of coarctation. So many of the time, the newer students, they're not actually palpating dorsalis or femoral. We should have still that practice to identify the coarctation of aorta. So those are the things I want to point out.
And cardiologist, all the inputs, great inputs. The probably learning, that should be our learning objectives today. But I will invite cardiologist from New Clinic, Dr. Bhatt. If she's around, she can any inputs she wants to give before proceeding. Did she join in the link? If she has joined, it's okay. Otherwise, we can. In the meantime, I will ask Rohit to just send the link again. She can join throughout the session. Her inputs end of the session was actually involved in the case managing. We will like to hear from her. In the meantime, Dr. Preeti can start the presentation.
Okay, sir. Hello.
Hello. I think she'll be joining in a couple of minutes. I think let's start with it.
So should I start?
Yeah, go ahead, please.
Good evening, everyone. Myself, Dr. Preeti Chaudhary, doing fellowship in Neo Clinic Children Hospital, going to present a neonatal cardiac case. My first case is baby of a female baby born at 27 weeks of gestational age by LSCS. Birth weight was 550 grams. Baby was shifted to our NICU in first hour of life in view of respiratory distress and for preterm care. Mother was elderly primary gravida, conceived spontaneously out of non-consanguineous marriage. Mother blood group was A positive. Mother was a booked case at a private hospital and taken regular antenatal visits. In first trimester, mother had took folic acid tablets regularly. First trimester scan was normal. There was no history of fever, rash, drugs, and radiation exposure. Mother was tested negative for HIV, HbsAg, and VTRL. In second trimester, mother took iron and calcium supplements. She received 1 dose of tetanus immunization. Mother was diagnosed with pregnancy-induced hypertension at 24 weeks of gestational age, and tablet labetalol was started. USG Doppler was done at 27 weeks of gestational age, which was suggestive of severe oligohydramnios and reversal of flow in umbilical artery. Single dose of antenatal steroid was given. Injection magnesium sulfate was not received by the mother. Baby was delivered by LSCS in view of aforementioned USG Doppler findings. Baby cried immediately after birth. Apgar scores were 7/10 and 8/10 at 1 and 5 minutes respectively. Birth weight was 550 grams, which was lying between 3rd and 10th centile according to Fenton charts. Delayed cord clamping was done. Injection vitamin K was given at birth. Baby developed respiratory distress soon after birth and was given delivery room CPAP. In view of severe respiratory distress, baby was intubated and shifted to our hospital within half an hour.
Preeti, I will request to just stop here, Preeti.
Yes,
Both
sir.
the faculties, neonatal faculties, Dr. Rohit and Dr. Sankal, if any inputs you want to give, because for the student, when the case presentation is going on, before going to the real clinical thing with the history, how to summarize, Dr. Preeti can do, and you can ask any of the questions, a short interaction, then we will break for the NICU course of the babies.
I think Dr. Preeti, you have covered all the details nicely. It is clear that the baby was delivered because of REDF, and you have covered all the relevant antenatal interventions to improve neonatal outcomes. Like you have emphasized on steroids, and even if Maxelf was not given, you have taken that negative history. That is very important. That tells us that you are aware that Maxelf is a important antenatal intervention. Then you mentioned about delayed cord clamping, which is very good. So I think all the fellows should definitely include these points so that these are pointers for discussion in the your exams, right? So overall, I think till now you have done summarized nicely. We can proceed further, sir.
Yeah. Just one or two points I would like to highlight here. You talked about magnesium for a preterm babies. The neuroprotection issue we know, but do we have any idea what this particular practice can affect your case? What is it going to present? Do you have any relation of a antenatal magnesium sulfate with the presentation what you are going to present in this preterm baby?
So, because magnesium sulfate has neuroprotective role, so we have to give magnesium sulfate before 32 weeks of gestational age.
No, that's clear evidence actually. So no ambiguity there. 30 weeks before, or preferably if extended up to 32 weeks. If any preterm imminent delivery, we are going to give magnesium sulfate for the preterm brain injury protection or long-term outcome. When we are talking, I'm talking now. Your presentation is a preterm PDA presentation. I'm asking, do you have any idea the magnesium sulfate influence on the preterm PDA's patency, symptoms, anything, any relation? Any evidence about antenatal magnesium effect on the preterm baby's PDA outcome?
So not on PDA outcome.
Okay, so for the trainees, this is a question they can answer in the chat box, and we can go and do the discussion later. And discussion will see the influences. And do any antenatal, are there any factors, antenatal courses or antenatal morbidities? Do you think anything can influence the PDA presentation or PDA outcome? One thing you have done a very good thing, delayed cord clamping. I think delayed cord clamping can modify the presentation. How the modification, how it can modify the presentation of PDA? If somebody has done delayed cord clamping, other did not receive the delayed cord clamping, immediate clamping and got the babies, are they going to behave differently when the initial 1 or 2 days in extreme preterm babies? Because these histories are important, very relevant histories you are giving, and it is a learning for all the audience today, the trainees who are going to present tomorrow. In the examination, these points to be covered, because each history having some influence on a cardiac disease, some influence on the neurological disease, some influence on the respiratory disease. If we know how it can influence, the history is relevant to you. We can justify the history's relevance here.
So delayed cord
clamping.
Yes, sir.
In the preterm population.
Yes, sir. It prevents, it increases hematocrit of the baby. It prevents IVH. It prevents risk of NAC in preterm babies.
Is it an effect on the hemodynamics or the blood pressure? Do you think the delayed cord clamping having any influence on the hemodynamics or the blood pressure of the baby in a small ELW baby in the first?
Yes, sir. As it increases hematocrit of the baby. Red cell volume, it increases red cell volume.
Okay, so for how long you should delay the cord clamping, delay the clamping?
So it is recommended 1 to 3 minutes.
Okay. Okay, so 30 seconds, 60 seconds, 90, or between 1 to 3, how much is relevant? How much, how do you decide? And
so as per baby's status, we can decide. Mostly centers, usually we also practice 1 minute.
So the beneficial, the curve, it flattens after 60 seconds. So between 30 and 60 seconds, definitely 60 seconds is much better than 30 seconds, because a lot of blood from the placenta goes between 13, but beyond 60 seconds, the curve flattens. There is no extra benefit beyond 1 minute. So most guidelines say 1 to 3 minutes. Suppose the baby was non-vigorous, right? Would you have done cord milking in this baby?
Yes, if a baby is non-vigorous, we have to start resuscitation.
Okay. So
Yes.
can I do cord milking, umbilical cord milking?
We can, sir.
Okay. Any possible harms of umbilical cord milking in preterm babies, particularly less than 32 weeks?
So it can suddenly increase blood volume of the baby.
And it can lead to increased chance of IVH. So preterm babies, usually less than 32 weeks, we avoid umbilical cord milking. And if they're non-vigorous, we clamp the cord immediately, start resuscitation. If they're vigorous, we go for delayed cord clamping. However, for late preterm and term babies, you can do umbilical cord milking in non-vigorous babies, right?
Yes, sir.
Preeti, I think Nalinkant sir has asked a very important point that how will, it was I think a specific question, how will delayed cord clamping help in preventing PDA? So I'm not sure about the exact answer, but I think as you said, it increases the hemoglobin. Apart from that, it will stabilize the blood pressure. And I think that blood pressure stabilization shall lead to lesser chances of duct reopening.
Right.
So
Sir.
should I continue?
Sir, you are mute, sir. Nalinka, sir, you are muted, sir.
Okay,
Please.
okay. Now probably audible. So what I was saying actually, Dr. Rohit rightly pointed out, I was asking this particular practice has many benefits in delayed cord clamping. We should do. It is not requiring any investment, no costly equipment required. It is very simple. We can do all awareness is the only key thing to do. And extreme to extreme small babies also we can achieve, and we are stabilizing the tertiary level care hospital, then neonatologist available with stabilization, we can practice probably. But coming to PDA, though many benefits are there, as Dr. Roy told, we are getting little extra volume. So the need of vasopressors of ionotropes are lesser in the ELBWB during the stabilization phase of first 3 days. If you don't need, means what the extreme low birth baby is hypertension usually caused, one of the major component is the PDA and the opening of the PDA or hemodynamically significant PDA. If you got a good volume and need of ionotrope vasopressors lesser, so symptomatic PDA components will be lesser. So treatment need to the PDA component will be lesser. PDA might be same, you're not altering anything, but a support of the volume, stabilization of the hemodynamic stability itself warrants less treatment or less attention, because unless there is a symptomatic, unless there is any intention to treat will be lesser. If you don't, you got a stable baby, probably your evaluation, asking for a cardiac help or evaluation to echo also may be lesser. And by not doing a 2D echo in a stable baby, your intention to treat will be lesser. That's the way the disease influences. That's the message. So please go ahead with the presentation. Then I will request all the faculties. It is not like didactic teaching. When Dr. Preeti is presenting, Dr. Preeti, feel free to present comfortably here. It is just a discussion. It is not an examination today. But when you are presenting, all the faculties I'm inviting to interrupt and give the message of the particular components of presentation to the delegates or trainees here. All the, including the cardiologists, please all free like a discussion, so that all the presentation points should be as a practice point should pass to the audience. Okay. Dr. Preeti, please go ahead.
Yes, sir. Baby was shifted to NICU under incubator care with the humidity 80%. She was taken on mechanical ventilator on SIMV TTV mode. Rate was kept at 40, tidal volume 5 ml per kg, Pmax set at 20, required pressure for 18, P for 6, and FiO2 was 50%. Injection surfactant was given immediately at admission. IV fluids, IV caffeine, and other supportive management was started. UVC were inserted. Post-surfactant therapy, ventilator requirement decreased in next 6 hours. TPN was started. Minimal enteral nutrition was started on live day 2. On live day 3, baby started deteriorating. There were increased ventilatory requirement and there were signs of poor perfusion. At the time of deterioration, heart rate was 188 per minute. CRT was borderline. Pulse pressure was peripheral pulses are bounding. Invasive blood pressure was 41 by 16 mm of mercury. MAP was 24. Pulse pressure was wide. Temperature was 36.5 degrees centigrade and SpO2 was 94% on mechanical ventilator. On general examination,
So, Preeti, I have one small question. So these are the vitals on day 3 of life, correct?
जी.
Why blood pressure is blood pressure or is normal on day 1? Diastolic pressures?
Yes, ma'am.
Okay. So what changed actually? Why it happened, this bounding thing, bounding pulse and all at day 3? Day 1 also you will have a PDA, but day 3 also you have a PDA clinically. But what is the difference?
Ma'am, because there will be increased cardiac output. There can be there will
So
be
the initial pulmonary vascular resistance is very high.
yes,
So
ma'am.
after that, you gave your surfactant, then your ventilation perfusion mismatch and all were decreased, vascular resistance decreased, then your left to right shunt is more, reversal was more. That's why you have a diastolic hypotension at that point of time. That was the reason, hemodynamic reason why your pressures are low at day 3. Okay.
Also, Dr. Preeti, I would like to add here that as an examiner, I would like to know which surfactant was used, how much was the dose. You just said surfactant was given. So which was used at what dose? That you should have mentioned.
So, Saventa was used at dose 4 ml per kg.
Okay. What is the current recommendation? What does the European consensus guidelines say?
So, surfactant in extreme preterm babies who are ventilated, surfactant must be considered in all
So,
extreme
yeah.
preterm.
Okay. So indication is if the child is on mechanical ventilation at any FiO2, you would consider, and or if the child is on non-invasive ventilation, 30% cutoff.
30%.
FiO2 requirement is more than that. But which surfactant is and what dose is 200 mg per kg better than 100 milligram per kg of phospholipid?
So usually we give Curacao that is 200 mg per kg.
So in extreme preterms and those who are required surfactant, 200 milligram per kg is better as compared to 100 milligram per kg, right? And for giving 200 milligram per kg, you can give only with Curacao because
Yeah.
the volume is less, right? So yeah. So any specific reason why Survanta was used?
So because of cost issue.
Okay.
it was-
Okay. Okay, so and surfactant, as ma'am has rightly pointed out, surfactant would lower down the pulmonary pressures and will cause precipitation of PDA, left to right shunting. Yeah, go ahead.
There were no abnormalities seen on general examination. On systemic examination, baby was intubated on SMV TTV mode. Bilateral air entry was present. There were no added breath sounds. On cardiovascular examination, precordium was hyperdynamic. There was continuous grade 3 murmur heard all over the chest. And abdominal examination, abdomen was soft. There was no organomegaly. AF was at level and spontaneous activity was present. By provisional diagnosis on the basis of history and examination, extreme preterm 27 weeker with small for gestational age baby with respiratory distress syndrome received surfactant with respiratory failure, with shock, with secondary deterioration. Differential diagnosis include patent ductus arteriosus, neonatal sepsis, pneumonia, pneumothorax, and interventricular hemorrhage. Chest X-ray was done to rule out pneumothorax, pneumonia, or lung collapse. There was no pneumothorax, no lung collapse. Homogeneous opacity seen in bilateral lung fields, suggestive of plethoric lung fields. Sepsis screen was negative. Complete blood counts, serum electrolytes, coagulogram were normal. Blood gas was suggestive of mixed acidosis with raised lactate. Cranial USG was suggestive of bilateral grade 1 IVH. 2D echo was done, which was suggestive of hemodynamically significant PDA. Duct size was 2.3 mm. Direction of the shunt was left to right. Duct flow velocity was 2.7 meter per second. Flow pattern of the duct was pulsatile pattern. LA by AO ratio was 1.4.
Preeti, there is a lot of discussion will happen on 2D eco. I know all the faculties will be interested to speak about 2D eco findings of PDA. Before that, as a neonatologist, I will just want to highlight it. Maybe you are ventilating, and what are the ventilatory parameters or situations when you will think, okay, this baby is this ventilatory deterioration may not be due to respiratory and maybe due to the cardiac. The baby may not be, if not in respiratory support, the deterioration is also in different form you can explain. But my question is very specific because extreme small babies usually first 2 to 3 days they will be on respiratory support. They are on mechanical ventilator, unlikely CPAP also first 2 days or first 1 day you can see on mechanical ventilator. So what are the parameters? So what are the changes in the clinical scenario will be pointed to you? Okay, maybe I'm dealing with a case of a PDA or something else rather than only pure respiratory.
So increased FiO2 requirement.
Okay. Okay, that's one point, perfectly fine. If previous whatever there was an improvement, post surfactant improvement, and you are seeing again there is a even the re-evaluation time there is increased need of the oxygen. It is a response to surfactant. Then again, if the need of FiO2 is increasing with your previous setting, or maybe the ventilator setting also increases sometime.
Yes, sir.
So ventilator need also might increase, the PIP, PWP increase, because increase means if the need is there, not increase, or nothing happens. So mean area pressure we have to increase sometime for improve the oxygenation, or any other thing, any point during the evaluation, anything other pointers. You have highlighted one is cardiovascular. You will say tachycardia, the white pulse pressure, bounding pulse, that diastolic, low diastolic. You have explained all things, the cardiac thing over. I'm focusing on respiratory. So if your FiO2 need is increasing, so you have given 1 dose of surfactant, there was improvement, and after 8 hours or 12 hours, there is again FiO2 increasing. What do you do for the baby? For a small baby like this baby?
So to rule out respiratory issue, we have done X-ray. There.
And treatment wise, if the guideline, what the guideline Dr. Sankalp was asking a few minutes back only, just I'm coming back to that again. So if the baby is such a small baby, thinking primary diagnosis of RDS HMG, you have treated with the surfactant. Now there is increased FiO2 need after few hours of improvement. So do you consider a second dose of surfactant here?
Yes, sir. Yes, sir.
When you will think of second dose of surfactant, and how will feel, okay, no, this is not respiratory, probably something else to find, but probably I have to find out. So you will consider at what time and what parameters, because worsening can happen due to the progressive same persistent RDS HMD or due to any other morbidities. One of the components is PDA. So I'm asking first cause, we have to think, okay, given response.
So increased pressure requirement to PIP, increased requirement of PIP, pressure requirement.
Objective guidelines, already guidelines laid down by European consensus, or the NNF. India also has given guideline at what point of ventilation parameters, at what point of oxygenation parameter I should think for a second dose of surfactant. That's because that's a learning for us. This is a discussion, is learning for everyone. So if you are ventilating, I will say you are ventilating with the 12/4. You are using 80% FiO2. Somebody will come back, will increase the PIP a little bit to 16 or 18, and PW to 5 or 6. Now the FiO2 need comes down to 25, 26. So there is only isolated FiO2 pointer FiO2 30, 40% may not be guiding us. So always it is with the ventilator parameter. So with what ventilator parameter, what FiO2 you will like to use a second dose of it.
So FiO2 requirement more than 50%.
So answers are coming probably there's in the chat box. So if you will just 30% or 40%, the range is 30 to 40. The guidelines are a little different in different recommendation, but 30 to 40. The primary guideline talks about 30, but secondary second dose surfactant also 30 to 40. But remember, if the inadequate ventilation, again the FiO2 need goes up, so there is always a cutoff of 8 or 7 mean air pressure. If you're using more than 7 or 8 mean air pressure, and then you are getting the FiO2 30%. Answers probably some of the trainees are answering here. I'm happy to hear, see that. So that's 2 parameters we have to speak. Why this discussion we are doing? Majority time the second dose surfactant over, still not improving. The guideline talks about a alternative diagnosis. Don't think only HMD. You initially X-ray is HMD, you given 1 dose surfactant, you given second dose as per the recommendation. Why in PDA case we are discussing second dose surfactant? But it happens. Third dose also 4 days we have seen. No. Second dose after, if you fail, effectiveness of a surfactant, you are thinking it's not effective. The secondary diagnosis, you highlighted well, sepsis, pneumothorax, other cause of respiratory perinatal depression possibility. There are PDA possibilities. So we have to open our mind and see that, okay, it is not a pure HMD case. We have to think about other alternative diagnosis. One of the diagnosis is PDA. We should not forget it, which presents early. Okay.
And I think
So
it's,
radiology.
Infradiaphragmatic TAPVR, that is most commonly actually we get with after second dose of surfactant, still pressures are high. It is a common thing also in cardiac.
So Dr. Bhargavi, you are rightly pointing out, because my next question was exactly about X-ray evaluation time, what do you look for? We saw about ventilator parameter, a HMD baby or ELW you are treating with X-ray. Then what X-ray findings will give a clues to, oh, it is not respiratory only, it has some cardiac cases sitting there. Because pneumothorax is easy to diagnose. Pneumothorax, tube factors, tube displacement, tube of, displacement high up or displacement towards unilateral one side, right side. Those are the things X-ray will guide. Beyond that, what are the clues will tell? No, it is not HMD. I have treated, it is not responding, it's some cardiac disease possible. So what are the clues you will look for in your X-ray also? So I was hoping that some X-ray finding will show it here. So what are the X-ray finding will look for?
X-ray you can show.
Can you go back to the X-ray?
X-ray, you showed an X-ray for the pneumothorax rollout, but any this X-ray, what are the things you will look for? What will give a clue to cardiac? This is. Can you describe this X-ray? Because routinely we bedside we discuss. Please describe your X-ray. So by that you will know the interpretation of all the components.
So this is the chest radiogram AP view showing film is slightly rotated. So this is showing bilateral homogeneous opacities are there, and cardiothoracic and so angles are normal. There is no cardiomegaly. Cardiac size is normal, and bones.
This is not homogeneous opacity, because homogeneous opacities are different. They're equal. Their distribution is pattern is different. But you can say these opacities, but irregular opacities, because this X-ray is giving diagnosis towards a different diagnosis now. But we will like to know when we are assessing early HMD, the volume of lungs and cardiac shadow. These are two important shadows we can talk. So please describe the volume of lungs here from this X-ray. This is giving him a different impression to me. This is not the HMD initially maybe, but after treatment, this is opacity is leading towards a different diagnosis now. So please tell me the volume of lungs. What do you think? Is a good recruited lungs or a poorly recruited lungs? I have to increase my ventilation parameter. Or a good recruited lungs are higher, so that I will decrease my ventilation parameter. These clues should come from the X-ray discussion. So what if
hyperinflated lungs?
So how you define hyperinflated? What you saw? You may be right. You are right only. But I'm saying why you talk that? Why the others should understand also? Okay, this X-ray I will see. I'm a little worried actually. So why you are saying so?
Rib
How many spaces are available?
nine rib. It's called 9 rib shadows. Lung.
So almost 9 ribs you are seeing above the diaphragm. At least you can define as a intercostal space or a posterior ribs. Whatever, both way can be defined. But if you are seeing rib space or the posterior ribs, any things you are seeing probably, and you can see the diaphragm also. It is bulging upwards or flattening. What you are seeing?
Straight. It's
high volume lungs. So ventilation wise, there is probably this is not a derecruited lungs or a collapsed lungs or a poorly recruited lungs. No, it is a very good highly recruited lungs. So maybe the respiratory components are well taken care. So it is now the respiratory is not bothering. It's something else we have to find out. Sometimes the air leak, early air leak signs. This is maybe a sign of PI, pulmonary interstitial emphysema, maybe beginning stage of this X-ray. So that's another worry. Sometimes we say, okay, we'll go on increasing the ventilation. No, it won't help us, because that's why we have to come down by seeing this type of X-ray. And as Dr. Bhargavi told, this X-ray time, please evaluate always to see other clues. Like, is it maybe pneumonia? Maybe PPRM or chorioamnitis was there. So is the patch of pneumonia is there? That's the respiratory. RDS is not the cause. A different patchy infiltration, asymmetrical lesions sometimes in preterm babies talks about early sepsis or pneumonia. Is it a cardiac? Cardiac sometimes is a pulmonary plethora, or we see typically obstructive TAV we see many times many people Dr. Bhargavi rightly pointed out, considering RDS multiple times surfactant, give surfactant, little clearance, again deterioration, give surfactant. So DAPVC sitting there and each time give surfactant, little clearance of fluid, improvement transiently, again deterioration. So think maybe we are, and saturation, little improvement up to 90s, again coming down to 75, 80s and 85s. So that time we have to think about maybe missing an epitom, maybe missing a TPVC. Use a late preterm babies, that happens more and more. So this X-ray, the X-ray analysis time, we should think all the differentials. So any of the faculties, any inputs, otherwise you can see present. She was presenting, I interrupted her. She can go back again.
I think very rightly pointed out, when we are putting this X-ray in the presentation, the first thing I said that it looks more of a PIE or evolving PIE, because maybe pressures were given a little higher, or although we use the TTV more, but this looks slightly hyperinflated. And other differentials, as sir said, it could be sepsis, pneumonia, which is really common in Indian setting, and especially in our case, where the history was like magnesium sulfate was not given despite knowing. So maybe properly the treatment of mother was not taken. So pneumonia and PIE, I think these should be the closest differentials apart from TAPVC, as Matt pointed out.
So yeah, so just based on this X-rays, I would like to come down on pressure, and there is no question of a repeat dose of surfactant. Even if they have to make cross 30, 40, whatever threshold, there is no question of a repeat dose of surfactant, because it is clear that the lungs are slightly overinflated. Definitely, one would keep sepsis as a possibility here, because sepsis and PDA, sometimes they are coexistent. Sepsis leads to inflammatory mediators that worsen the PDA. So based on the inhomogeneous infiltrates on the right side, I would definitely keep pneumonia and infection as a possibility. And yes, there are cystic shadows here and there, most likely because of early evolving PD. So those babies who are having these kind of cystic lucencies in the initial few days of life, we have seen that they end up evolving into BPD eventually. So I think, and the differentials that you showed, Dr. Preeti, in the order, I think those were very nicely put. You have covered all the differential. You have not straight away thought of a second dose of surfactant, and you have thought of all the possibilities like pneumothorax, infection, PDA. So that's very good. I think you can proceed.
Sepsis screen was negative. Complete blood count, electrolytes,
Let's come to the echo part. This has already been done. Yeah.
Echo was suggestive of hemodynamically significant PDA. Duct size was 2.3 mm. Direction of the shunt was left to right. Flow velocity across the duct was 2.7 meter per second. Flow pattern was pulsatile. LA by AO ratio was 1.4.
Preeti, you have shown neurosonogram, no? You want to ask the radiologist any other things when you are suspecting PDA in that? So you are thinking because of diastolic low PDA, and we did a neurosonogram. You want to, please, because we want to, you can ask us questions. You have to ask this you have seen, this you have seen, then only it will be correct. So what are the things you want to ask the radiologist when they are seeing a hemodynamically significant PDA neurosonogram wise?
Ma'am, one thing is interventricular hemorrhage.
Okay.
And findings related to PVL in.
So middle cerebral artery MCA Dopplers are also very important when you are seeing a hemodynamically significant PDA child. So that you have to ask. So to assess the runoff, what are the Dopplers? So that you have to ask. Okay. Okay.
Preeti, just a broad sense, all the inputs will come because a lot of discussion happening here. Just I'm saying, when you are trying to evaluate, always ask the question to the radiology when we are doing, or we are ourselves and point of care we do, or the cardiologist help we are taking. What are the signs of pulmonary overload you are seeing, or systemic hyperperfusion you are seeing? Both the components and the pulmonary overload situation. Not only talking about anatomical diagnosis, but functional assessment of the PDA. Functionally, how impairs your oxygenation by influencing some of the lungs parameter, by influencing some of the systemic parameter. So systemic hyperperfusion, so abdominal finding, abdominal, when you are doing some ultrasound, what finding you will ask. Cardiac, when the other peripheral arteries, you are saying what exactly you want to know. Brain, when you are sonogram is easy tool, you are doing what the Dr. Bhargavi was asking, because PDA evaluation, you may be learning stage, but you can learn faster the other ultrasounds. Point of care, you do routinely. So at least you ask question and do that documentation when you are seeing a symptomatic PDA. That's a broadly I'm saying, but let's this is discussion about 2D echo, the patterns, the diagnosis. Please, I will like to hear from all the faculties a little more, so that our trainees will learn better. And when we are just when to ask 2D echo, if the 2D echo is available, how to interpret, how to grade it, how to make into intention to treat action, and just we know the PDA, but when to treat it. These all things I would like to discussion here. So please, all the faculties can lead with this discussion.
So not all the ducts needs treatment. That is the major important. The ducts which are hemodynamically significant, causing your pulmonary overcirculation or systemic hypotension only needs treatment. So it should be a clinical assessment first. Then when you have shown the duct size is 2.3, I'm very happy the flow velocity was written 2.7 meter per second. So Preeti, what it suggests the flow velocity, systolic flow velocity?
It's flow velocity across the duct. Sorry, ma'am.
So if it is, I would say if it is 1.5 meter per second or 1 meter per second, what it suggests, and it is 2.7 or more than 3, what is it suggests?
Ma'am, if it is more than 2, it suggests a hemodynamically significant PDA.
Okay. So I will tell you. So it actually flow velocities or the gradients which we write in the PDA, it tells about the difference in your pulmonary and systemic pressures. If your velocities are high, that means the PDA is getting it. There is some restriction at the PDA. If velocities are low, that means it is a long, like it's like a long tubular tunnel, F-type. There are types of PDA. It's called as fetal PDA or F-type PDA in preterm, which is very long and elongated. So then you will not have any restriction is not there, then your velocities will be less. So the important things is flow pattern you have mentioned, pulsatile pattern. So you know the patterns of the PDA?
Yes, ma'am.
Doctor?
I have mentioned, ma'am.
Mentioned in the PPT.
Yes, ma'am.
Okay, then you can continue. So other things you have to see is any flow reversal in descending aorta or celiac axis reversal that we have to see in that one. And recently, sometimes the PDA and LPA ratio is also given. So that is also important in preterm PDA. So these are all the things to be mentioned in the when we are assessing 2D echo. Size of the duct, direction of the flow, what is the velocities or gradient, then what is the flow pattern, is it growing or constrictive, high velocities, PAH is there, so LA-AVO ratio, and I would sometimes we will give a report. For example, I am telling, we'll tell a 2.5 mm PDA completely left to right, velocity of 3 meter per second, mild TR gradient of 30. So, and dilated left heart. So if you have these type of things and systolic blood pressure is about 60, 65, then it is not severe PAH. So you have to differentiate, is the child is having severe PAH or flow related PAH, and this PDA should be closed or should not be closed. These are also important things in that. So left heart dilatation, complete left to right PDA is mostly, it's a hemodynamically significant and needs closure. Okay. With flow reversal in the abdominal aorta. From neonatal, Dr. Sankalp and Rohit sir.
So, Dr. Preeti, yeah. So whenever you get an echocardiography for a PDA, one thing is the size of the PDA. You know? So we divide it into small, moderate, and large based on the size. The velocity is important. As ma'am said, that if the PDA is small, the velocity will be high. If the PDA is large, velocity will be low. Right. So I'm happy that the PDA velocity is 2.7. Had it been 1.52, then that means the PDA is rather large. right? Direction of shunting is important. Associated pH is quite important. So if the cardiologist tell us that there is a moderate to severe pH and PDA is rather right to left, would you like to treat it? The shunting.
Yes, sir. Left to right to left.
No, sir
No.
is saying the PDA is shunting from right to
Right
left.
to left.
You
Right
treat.
to left.
No, sir.
No. So if the PDA is there in a setting of a pH, moderate to severe pH, and PDA is rather acting as a pop-off valve for the high pulmonary pressure, so one would not like to treat it, right? And then I would also want, as far as PDA is concerned, there are, one is the dimensions of PDA velocity, PDA characteristics, then signs of pulmonary overload and signs of systemic hypoperfusion. What are the signs of pulmonary overload one would like to see?
So we have parameters for science.
So what are the parameters in the
This is
echocardiography which
slide.
indicate quantify pulmonary overload?
Yeah.
So,
Can you open that slide which we have kept in the discussion part?
so
I
we have to
covered it.
look the size of LA, LV.
Okay. If it's coming, we'll not go there. Okay, so we'll discuss it later when you come to the discussion. So you have to ask the cardiologist to tell you the parameters which tell us about pulmonary overload, about systemic hypoperfusion, right? And based on all of these, you take a call whether the PDA is hemodynamically significant or not, and then I would like to treat it or not. You should not treat all PDAs, right? And what are the contraindications for treating a PDA, large PDA? One, if there is associated pH. Second, if there is a duct dependent.
Please.
Yes. So I would like I would ask the cardiologist to look for duct dependent systemic or pulmonary circulation, right? Okay. So yeah, sir.
As Dr. Preeti, you are doing very mental management. You came very well. All the evaluation. I think one quick question I'll ask. Injection paracetamol you are planning to give 15 milligram per kg dose and 6 hourly. And so before that, do you want to take some precautionary test or something?
So if we are planning for paracetamol, we have to see liver enzymes for signs of hepatic failure.
Yeah. So the way the endomethacin brufen also, we have some guideline. What are the investigations to do pre-medication? So there is a paracetamol, we should do a liver function test to know any existing active coagulopathy is there. That question you have to ask. The acute coagulopathy also may be acute liver function dysfunction. Along with coagulopathy, any transaminitis is there or not? These two informations from liver function test we want to know. So that before giving the medications. So proceed, please proceed.
Supportive measures continued, fluid was restricted, inotropic support started, injection paracetamol at the dose 15 mg per kg per dose started, given every 6 hourly, blood culture was sent and IV antibiotics were started. FiO2 and inotropic requirement decreased gradually over next 48 hours. Blood gas was improving. 2D echo was repeated after 72 hours. It was showing a closed PDA. This is the repeat echo. Currently, baby is 8 days old. Baby has feed intolerance in form of abdominal distension and bilious aspirates and choke on life day 7. So baby was kept NBM. Repeat echo screening was done, which was normal. Sepsis screen was positive. Blood culture was recent. IV antibiotics were upgraded. Currently, baby is NBM on mechanical ventilator, on TPN, inotropes, and IV antibiotics. Now coming to the discussion part, patent ductus arteriosus. It is a communication between pulmonary artery and descending aorta. In fetus, as there is high pulmonary vascular resistance and lower systemic resistance, the shunting of the blood through the ductus arteriosus is right to left. After delivery, as lung expands, pulmonary vascular resistance decreases, and as umbilical cord is clamped, systemic vascular resistance decreases. This leads to shunting of the blood from left to right. In fetal life, patency of ductus arteriosus is maintained by low arterial oxygen content, endogenous vasodilators like prostaglandin E2, nitric oxide. In term babies, functional closure of the duct occurs at 12 to 24 hours of birth, and anatomical closure occurs at 2 to 3 weeks of life. In preterm babies, ductal constriction is delayed. Complete anatomical closure may take several months. Reopening of duct is common. Ductal closure is delayed in infants having RDS and who did not receive antenatal steroids. Now, practical aspects. When to evaluate for the PDA, when and whom to treat, and how to treat. First, when to evaluate for PDA. There is no role of routine screening. Evaluate only if there is need for substantial respiratory support, MAP requirement more than 8 centimeter of water, FiO2 more than 40%. There is evidence of hypoperfusion that are not explained otherwise. Clinical signs like bounding pulsation, wide pulse pressure that is more than 25 mmHg, diastolic blood pressure less than 50% of systolic blood pressure, or presence of pulmonary rales. Chest X-ray suggestive of plethoric lung fields or cardiomegaly. Now, when to treat? Only hemodynamically significant PDA needs treatment. When to say hemodynamically significant PDA? On the basis of clinical findings along with echocardiac parameters. There is no role of prophylactic therapy. Now, echocardiographic parameters. For ductus arteriosus characteristics, we have to see duct size, direction of the shunting, and flow pattern. For pulmonary overcirculation, left atrium, left ventricular size, LA by AO ratio, left pulmonary artery diastolic velocity, E by A ratio, and LV function. For systemic hypoperfusion, blood flow through the descending aorta in celiac trunk, superior mesenteric artery, anterior cerebral artery, and middle cerebral artery.
Preeti, you have kept very nice slide actually, pulmonary overcirculation, systemic hypoperfusion. But did you understand LPA diastolic velocity?
Yes, ma'am. We have to see left pulmonary artery. We have to put pulse wave Doppler on left pulmonary artery, and we have to see pattern of the flow.
So normally without PDA left pulmonary artery, what will be the velocity? You have the pictures, huh? That one.
I'm not having picture of
Okay.
that.
See, normally velocity will come in systole only because RV is contracting main pulmonary artery, RPA, LPA. You will have only systolic flow. You will have a systolic velocity. But when there is a large PDA just adjacent to your left pulmonary artery, some diastolic flow also left to right come, and it comes into during relaxation of the heart also some flow from PDA comes into LPA. That is the reason you will have a LPA diastolic velocity. Normally, we don't have LPA diastolic, means forward flow in the LPA will not be there. Only when there is a large duct which is causing whole this abdominal aorta reversal, descending aorta reversal of flow, PDA, and coming to LPA, then only diastolic flow will be there. Okay.
Yes. Now, ductus arteriosus characteristics. If duct size more than 1.5 mm, direction of shunting left to right, and flow pattern, it can be growing or pulsatile flow. Pulsatile flow is a non-restrictive type of flow. In this, peak diastolic velocity is less than 50% of the peak systolic velocity when we put pulse wave Doppler.
So here you will have a difference of your systolic and diastolic velocities that suggests it's a large PDA. If you don't have like minimal difference with the systolic and diastolic velocity, and you will have a like continuous W type of pattern, that is which type of PDA?
That is growing pattern.
High velocity, but the difference between systolic and diastolic is less.
Closing
PDA. That is a closing PDA. Same thing with low velocities, low difference is a growing PDA. So these are the patterns. So actually, I like the first slide. We should not no duct to be assessed generally. Only clinical indication we have to ask echo. That was the first slide. When to treat? No, I like that slide.
Now, pulmonary overcirculation. In apical four-chamber view, we look for left atrium and left ventricle size. LA by AO ratio, if it is more than 1.4:1, it is significant. In parasternal long axis view, we put M mode and intersector on left atrium along with the aortic wall and right ventricle. The pattern will be like this. We measure AO diameter at end diastole and LA diameter at end systole. And we see the ratio. If it is more than 1.4:1, it is significant. Left pulmonary artery diastolic velocity, if it is more than 0.2 meter per second, it is significant. Now, E by A ratio.
So this is E by A ratio at the mitral valve.
Yes,
So
ma'am.
we take at the mitral valve inflow. So normally what happens during fetal life and neonatal life, your E wave will be small, A wave will be tall. As the age grows, like 3 months, 6 months, then into young adult and all, your E will be tall, A will be small. So when there is a pulmonary over circulation, what it happens, it equalizes or E will become more than A. So that is what
For
we
the
are.
fellows, please tell what is E, what does E stand for, what does A stand for? I'm sure many of them may not be aware of that also.
Yes, sir.
Hmm.
It's like early.
Uh,
So that is one. So when you are opening the mitral valve, that is the inflow, how it is causing. Then A is the atrial wave. The atrial kick wave also will come. So these are the two waves which we see. So what will happen during fetal and neonatal, there will be still the restrictive physiology of the ventricles will be still high. Means relaxation properties of the ventricles will not be there. It will be slowly relaxation. So that is the reason E wave inflow velocities, first wave will be small. After that, with the atrial kick, more volume will come into your ventricles. So that is the reason A will be more and E will be small. So slowly as the age advances, ventricular relaxation properties will be good. Diastolic function of the ventricle will be improved. Then your early wave, E wave will be better, then A wave will be small. Okay. So in pulmonary overcirculation, we also see how is the pulmonary venous return. So if there is when we are seeing the fourth chamber, if you are seeing pulmonary venous return gush of flow is there, that is also a overcirculation of the due to PD, any shunt lesion overcirculation.
So to put it differently, when there is diastolic filling of the left side of the ventricle, initially there is passive filling of the left ventricle, which is called early filling, and then there is active filling by atrial contraction, which is seen as the A wave. Normally, in term babies, E wave early filling is larger as compared to A wave because the passive filling is more because the ventricles are more compliant, right? And in preterm babies, they are almost equal. However, if a preterm baby has a large E wave as compared to A wave, then you should think of pulmonary overcirculation. In PDA, in preterms, the E wave will be larger because the atrium are overloaded. So as soon as the valve will open, there'll be passive filling will be more as compared to active filling, right? So this is E being larger than A is one of the parameters of pulmonary overcirculation. So we have discussed various parameters. Can you show the previous slide?
Yes.
Practically, we have seen that among the next ones, pulmonary overcirculation, we have seen practically for residents, LAA ratio is the simplest. You can put your probe in the parasternal long axis view, take M mode, and you should know where to measure LA and where to measure AO. So LA to be measured at end systole, which is usually the largest point, and AO at end diastole, right? And you compare the two, more than 1.4:1 is suggestive of a large pulmonary overcirculation, right? And more blood coming back to the left atrium, right? And second, EA ratio can be done. It's a marker of diastolic dysfunction or pulmonary, overcirculation. So practically, LA ratio is something that all residents should be aware, and this can be done to measure pulmonary overcirculation.
Now, systemic
They
hypo.
have to ask what is the LAO ratio. That is what I want after this class. When we are assessing PDA, they have to ask us size and LAO ratio also.
Yes.
So what I was thinking a day, that whenever we order a preterm eco, I think we should give a different performer what you usually have. We should write, we need these 5 to 10 points, and
Yeah.
so that we can have a more focused approach. So maybe in all our units, we can develop one such, and whenever the cardiologists we involve, I think we should specifically ask them, this is we need in pulmonary hyperperfusion, this is we need in systemic hypoperfusion, and this is what we need for the duct. I think
Said that.
Agreed, Dr. Phil.
For systemic hypoperfusion, we see diastolic flow reversal in descending aorta, decreased blood flow in celiac trunk and superior mesenteric artery, increased flow in anterior cerebral and middle cerebral artery on cranial USG. Now, goal of treatment to reduce morbidity from effects of excessive left to right shunting and ductal steal, to ensure timely treatment in infants for whom PDA is contributing to signs of respiratory distress or other neonatal morbidity. Morbidity caused by pulmonary overcirculation include pulmonary edema, pulmonary hemorrhage, BPD, and pulmonary hypertension. Morbidities caused by systemic undercirculation are hypotension, necrotizing enterocolitis, IVH, and acute kidney injury. Now, algorithm for treatment. Provide supportive care and manage expectantly initially. If patient remains ventilator dependent even after 1 week of age, or patient has signs of hemodynamic instability like hypotension requiring vasoactive therapy, oliguria, or lactic acidosis, which are not otherwise explained, we have to start pharmacological therapy.
So, Dr. Preeti, just one point here. We'll discuss pharmacological therapy later. You said provide supportive care. What all is included in supportive care of PDA?
Maintain thermoneutral environment to decrease the metabolic demand of the baby, appropriate respiratory support as per need, maintain hemodynamic stability, with starting inotropes or fluid restriction.
Hmm. So, how much fluid restriction? Suppose per day requirement for the baby is say 160 ml per kg per day. Shall I give give it half, reduce it to half? How
So
much fluid restriction?
we can give 130 to 140 ml per kg per day.
Yeah, so you can restrict up to 2/3, but should not go less than 120 ml per kg per day, right? That will lead to systemic worsening of systemic hypoperfusion and AKI, right? So fluid restriction is one. Should I be routinely using diuretics if suppose there are signs of pulmonary overload?
No, sir. First, we have to do fluid
What is the
restriction.
effect of furosemide on PDA?
Yeah.
It worsens PDA
It
because
increases prostaglandin synthesis and it rather worsens PDA, right? Good. And what about PEEP? Anything in ventilation should I be doing if there is a PDA? Should I use a higher PEEP or lower PEEP?
we can use we have to give lower PEEP.
Okay. Why? Generally, it is recommended to give a adequate PEEP in order to prevent left to right shunting. So at least adequate or higher PEEP if there is a underlying PDA, right? And thermoneutral environment and all those things you said. So fluid restriction. You said that the baby was started on dobutamine. Should all babies with HSPDA be started on inotropes?
No, sir. If a baby is not maintaining BP even after doing all other supportive care, then we have to start inotropes.
So
Okay.
how vitamin will
Yes,
help?
to maintain blood pressure, we have to start inotrope.
Okay.
Because
How would dobutamine help in maintaining blood pressure?
Yeah.
so it increases cardiac contractility. It will help in improving LV dysfunction.
Your baby had LV dysfunction? I think it's normal function, no?
Yes.
Means we are asking what is the role of dobutamine and when to start. It's not like all PDAs require dobutamine.
DBP, as SBP, systolic blood pressure is normal, and diastolic blood pressure is going down. So to maintain.
So if the child has PDA, not all PDAs, we will start inotropes, right? So if there is evidence of left ventricular dysfunction, we will start inotropes. Suppose there is left ventricular dysfunction and normal blood pressure, then which inotrope is preferred? Suppose there is left ventricular dysfunction and low blood pressure, then which inotrope is preferred?
So if LV dysfunction is there and blood pressure is low, we have to give dobutamine. And if
so dobutamine, so blood pressure is the product of cardiac output into peripheral resistance, right? So dobutamine will reduce peripheral resistance and will reduce the blood pressure, right? So if the blood pressure is low with LV dysfunction, I would prefer not giving dobutamine. I would rather give dopamine or adrenaline, right? Because they will cause systemic vasoconstriction and increase peripheral resistance. However, if the blood pressure is normal, then only I would consider dobutamine or milrinone. Dr. Nalin sir, if you want to add something.
I'm listening. It's perfectly going well. Just the PDA for shunt diagnosis, shunt volume assessment, and the pharmacotherapy is different. Here, Dr. Preeti has pointed out towards the different aspects. If I am seeing PDA, I have to ask my ventricular dysfunction, either in the form of RV or LV. The first primary agent I will choose dobutamine. But as Dr. Shankar clearly told, cardiac dysfunction, with a low BP, very low hypertensive. That time, the first prefer agent, if I'll start dobutamine, I know there is a cardiac dysfunction, but and now that is we are seeing a significant hypertension. That may be for me a bedside adrenaline will be a better choice. Then I can see later I can add on dobutamine or can I replace or manage with single agent of adrenaline. So the first question you have to ask: only PDA, only shunt is issue, or cardiac dysfunction in the form of LV or RB dysfunction. LV, RB dysfunction without hypertension, dobutamine is the preferred. With hypertension, I will be a little skeptical about dobutamine, the first choice. Maybe we'll start with adrenaline, then I will think about what to do further. The milrinone, other thing, if mainly milrinone we talk when the pulmonary hypertension or other cardiac dysfunction related to RV is key. But PD related, not the first stage until milrinone, but we can choose later after stabilization, the blood pressure stabilization.
So Dr. Preeti, we are left with two inotropes, NORAD and vasopressin. Can you, in a nutshell, just say, would you use or not, and why? Yes or no?
So
NORAD and vasopressin. So all others have been clarified quite nicely by everyone.
So NORAD causes it increases peripheral vascular resistance. So we should avoid.
So yes, NORAD would increase the peripheral, and in fact, it would worsen our case. It would increase the left to right shunting, leading to pulmonary over-circulation and systemic hypoperfusion. So no to NORAD and vasopressin.
So all probably cardiac hemodynamics we are speaking well, but coming to the primary pharmacotherapy, I will ask few questions here. I say that so we have to switch over to the next case because we don't have time. But one or two only, if all the plethora of medications available to you, like endomethacin IV, if oral ibuprofen and IV ibuprofen, which is available in India now currently. IV was not there before, it is available currently. Oral was there since long before, and IV paracetamol. Everything is available to you. As a clinician, how will choose which one to choose? The first most preferred agent among the all. Then I will go second preferred. Then I will third preferred. How will choose?
Sir, as efficacy of all the pharmacological therapy is equal, our unit prefer paracetamol because side effects are less. Alternatively, we can give ibuprofen because side effects are comparative to endomethacin. Side effects are lesser. The first.
I'm asking Priti, my question is, in India, some limitations are there, ibuprofen availability. And the salt which is preferred internationally is lysine or arginine salt. And the third alternative is sodium saltobrufen. Is not available in India. That's the issue is non-availability. If available to you, your unit may be preferring IV paracetamol because EG access side effect profile is better, effectiveness comparable. But when there's an absence of brufen, the tomorrow in the market somebody enters brufen because there's information, scientific information, international recommendation. I'm asking brufen, paracetamol, indomethacin, all three available. How will go for? How will what the preferred agent? What the next preferred? What is the next preferred? That's why I'm asking.
So, preferred is paracetamol because of lesser side effects comparative to other two drugs. And if there is liver dysfunction or coagulopathy, we can switch to ibuprofen because. But before that, there must be platelet count must be normal and no NEC, no.
So, Dr. Preeti, I agree. You are probably strongly believing in paracetamol. So, you are not moving away from the answer. But I will ask my faculties if the international recommendation, I don't think any of the recommendations till now came, is FDA, European, or the Canadian guideline. Any of the guidelines that didn't place the paracetamol as the preferred agent. So, as a practitioner, tomorrow you are going to present a case, somebody asking, thus we should know the right approach. So, any of the both the faculties, I will request to help little Dr. Preeti in regard, because he is so confidently saying paracetamol. I won't move away from paracetamol.
Preeti, I think you know the dictum, old is gold. This might have a hint to you.
Dr. Preeti, so
we will prefer ibuprofen.
So practically most units have shifted to ibuprofen. We use paracetamol. We use paracetamol frequently. But for your exam, for your case presentation, you should be aware of what guidelines say and what is the standard of care. So no guidelines, as sir said, say paracetamol as a standard of care. The drug of choice, as they say, is brufen currently, and paracetamol has been shown to not be non-inferior. We are using it in our units frequently, but it is still not the drug of choice or standard of care. For generally for your exams and for your both your theory and practical, you should say brufen. Are you aware of any network meta-analysis where the all the modalities have been compared and what was the result? It was recently published in JAMA Pediatrics last year.
So there Oscar trial.
Oscar is one of the trials, but any meta-analysis which has compared all the modalities.
Epiphysis 2 trial.
Meta-analysis was published and they proved that oral brufen at a higher dose, 20, 10, 10, 20 loading, 10 maintenance, 10 day 2, day 3, is more efficacious as compared to conventional, and they without increase in side effects, right? So, however, we frequently use conventional wala 10 mg per kg as loading and 5 as maintenance on day 2 and day 3, right? Paracetamol has been shown to be non-inferior, so that can be used if there is platelet dysfunction or brufen is contraindicated. When you present a case with any case in general also, you should also be aware of latest evidence as well as latest, including the latest trials. Like in the context of PDA, trials like Oscar, Benedictus, Tolerate, these were some trials, landmark trials, which were published in the past few years. So you should be aware of their results, right? And the current consensus is, as we have told, is one should not treat all PDAs, only if it is HSPDA and there are some symptoms. Although all units follow different protocols, but this is the current overall consensus. What about prophylactic treatment of PDA? Would you consider giving indomethacin to all extreme preterm babies? And What
No,
is the current status?
prophylactic is not recommended.
What is the benefit? What is the harm?
So, early prophylactic treatment, it closes PDA early, but in long term, there are no in view of BPD, NEC, there are no long term benefits.
No benefits in terms of BPD or long-term neurodevelopment. Any short-term outcome which was better by giving prophylactic treatment?
So I think when you were not here doing fellowship here, I think 5-6 years back, we were struggling with a important entity. That's the hint. And that was the time we used to use indomethacin in our unit around 5 years back, I think. There's a trial also, very important trial. You can just point out.
This is a good tip sir has given to you.
So one thing actually, for all the trainees, I want to say, Dr. Probably both of the faculties, not one, both you highlighted about prophylaxis thing you asked, but I want to give a clear message. Prophylaxis is not the practice. To highlight that only the discussion initiated. Why? The simple reason I will say, a medication with anti-inflammatory medication may contain a lot of side effects for extreme small babies. But if needed, indicated, we can use it. But the crux here, 65% or 55% different populations spontaneously close. So if you use prophylaxis, those overexposure to the 55 to 65% PD you are going to give. If you don't give prophylactic, only wait for early treatment where hemodynamically significant PD you are identifying by 2D echo, point of care ultrasound, 2D echo, not waiting for late symptoms. That's also the clear message. We are not waiting till late symptoms, all organ failure. We are identifying in the early period with the 2D echo and we are treating. Still, we are avoiding 50 to 55% cases of PDA if we will put on prophylactic. That's the major gain. That's the only gain I will say. Prophylactic you treat, it will close. But you don't treat, wait, evaluate and treat, you will avoid 55% cases to 65% cases. Only 35 or 30% cases you are going to treat. So you avoid exposure of 3 days of Brufen or 5 days to 3 days of paracetamol to the baby. That is a very simple answer that way. Then the question comes, okay, which drug, when to treat, when to identify, that question comes later. Okay. So this question, probably many relevant questions will come, but I will request to switch over to the coarctation because we won't get time. Briefly, 5 minutes to 7 minutes, what the challenges in the diagnosis, how to manage. Briefly, Dr. Preeti, you present the coarctation case. Then we will try to take some last 5 to 10 minutes, we'll take the questions from the delegates because their questions also to be answered. So if you have the case, briefly, history we won't go because history we know the preterm history, that term history will bypass it today. Directly go to the cardiac presentation and management.
So baby presented to us in emergency room in gasping condition and in choke, for which baby was intubated immediately and shifted to NICU. On admission, vitals were there were tachypnea, respiratory rate was 62 per minute, temperature 97.5 degree Fahrenheit, RT was 5 seconds. Saturation in the right hand was 94%, in right foot it was 82%. Peripheral pulses in right upper limb were well felt, and in lower limb pulses were feeble. On systemic examination, cardiovascular point of view, there was gallop rhythm, no visible precordial impulses. S1, S2 was normal. On abdominal examination, liver was 3 centimeter palpable, and spleen is not palpable. Activity of the baby was dull, and pupils are bilateral normal size and normal reactive to light. So on the basis of history examination, my provisional diagnosis is baby was early term 37 plus 5 weeker AGA with respiratory failure with stroke. Differential diagnosis include critical congenital heart disease, sepsis, pneumonia, or inborn error of metabolism. Sepsis screen was negative. Electrolytes, renal function tests were normal. Serum ammonia was normal. Blood gas was suggestive of metabolic acidosis with raised lactates. Chest X-ray was showing cardiomegaly. CT ratio was 0.76. On 2D echo, there was severe juxtaductal coarctation of aorta, small PDA shunting right to left, severe TR, severe PH, right atrium, right ventricular dilatation, and severe biventricular dysfunction. So these are the echo images. So management, initially baby is stabilized, airway, breathing, circulation, which maintained. In prostaglandin infusion was started. After stabilization, baby was shifted for surgery. On life day 12, coarctation repair and PD ligation was done.
So just wait here, Dr. Preeti. Can I ask a few questions, sir?
Um,
So your differential diagnosis of sudden deterioration at this age are you have covered all the important points, like one should think of critical heart disease, infection, and inborn errors of metabolism. Congenital adrenal hyperplasia, etc., are also covered in IEMs, right? So if you have a baby who has critical congenital heart disease that has come to the emergency, what all will you do? How will you stabilize the baby? You will do temperature, airway, breathing, circulation. Will you consider starting prostaglandin immediately, or would you wait for echo to be done?
So, we'll wait for echo to be done.
Okay.
So you was done 12 hours later. What you will do?
Yes, ma'am.
Echo cardiologist is not there. Nobody is not there. It's in a peripheral center. Actually, sir asked very relevant question because your clinical findings are there where your pulses are weak. And I want to know about your urine output also. How is the urine output of the child? That is very
It was,
important in the.
It was decreased, ma'am. I have mentioned in history part.
Okay.
Yes, ma'am.
So you have metabolic acidosis, lactates are increased, urine output is decreased, your femorals are not palpable. Blood pressure in the femoral means lower limbs is noted, or I think not noted.
Can you show the
So these
clinical
are all.
parameters?
So, sir's question is, and cardiomegaly is there, your X-ray, so much of cardiomegaly is there. So you want to start prostaglandin in the emergency room itself or not? What is the FiO2 you want to give if you're ventilating? Correct, no, sir? That's the what you
Yes,
want
yes.
to ask.
Yes, yes. Would you wait for a echo? Suppose echo is taking time, or these parameters are enough. No, these parameters are enough. There is weak femorals, cardiomegaly. There is a likely left side obstructive lesion. So
Yes.
one consider starting prostaglandin while waiting for an echo to be done. And
Yes.
what is the starting dose of prostaglandin? What is the dose that you start with?
So initial dose to start at 0.05 to 0.1 microgram per kg per minute. And then it can be tapered to as low as 0.01.
Okay. So 50 to 100 nanogram per kg per minute, you're saying, right? And
Yes.
okay, so how do you choose the starting dose? What is usual starting dose? I think 0.05 or 50 is the starting dose, and then you go up in multiples of 50, and you can go up to 200, and some units, sometimes we have to go up to 400 also, nanogram per kg per minute. And generally, left side obstructive lesions, they require higher dose of prostaglandin, right? And I think all residents should be aware of using this drug in all critical
Effects of
whenever you. What are the side effects, ma'am?
So it can cause apnea and hypotension.
Yes. So I think all residents should be
Super.
aware. Sorry, ma'am. Go ahead, please.
As sir relevantly told, for the left side obstructive lesion, systemic outflow obstructive lesions, you should need high dose of prostaglandin. But if you have a pulmonary dependent, duct dependent lesions, we'll give 20 to 30 also, the saturations will be maintained. Okay. So because we want the PDA to be completely opened up in systemic outflow coarctation, so there will be no gradient across the PDA also and no restriction. So your LV function will be better. That is the reason we give higher dose of prosta in systemic side rather than in PDA side, pulmonary side. If there is mild restriction also, it is okay. Flows will be maintained. That is one thing. And another effect here, I think it will be ventilated only because of biventricular dysfunction, child is gasping, gallop rhythm. But whenever you are starting prosta, very important things is airway management is very important. That is a major thing in that airway management. And you started prostaglandin, surgeon is not there, for example. And after that, you have a WBC count is raising, CRP is raising, and child is becoming edematous. So will you call, what do you think there? Because this is a common practical in cardiac ICU, neonatal cardiac ICU things. So day 3 of 50 nanograms of prosta, child became edematous. So what you want to do? So edema and third spacing is also a side effect of prostaglandin infusion. It's not like sepsis, and like avoiding surgery is not correct, or balloon dilatation as a palliation is not correct. It's a side effect of prostaglandin, third spacing of the fluid, not sepsis. I mean, sepsis can be there, but I'm just telling you, most of the time that will be the discussion point. Is it sepsis or anything? So again, say you want to give any inotrope here, biventricular dysfunction.
Yes, ma'am.
So what you want to give, if you want to give? It's a structural obstruction. Can you give adrenaline here? Adrenaline or your NORAD or vaso, which increases SVR?
No, no, ma'am.
No. Can you give dobutam, means vasodilatation?
Ma'am, yes, we.
Actually, it's a structural obstruction. No inotrope actually works in these cases, because vasodilatation also, you're vasodilating and then there is an obstruction and then you are peripherally vasodilatation. That is also not works, but many centers sometimes they use low dose or 7 micrograms of dobutamine, but vasopressors will not work, which increases SVR, or dilatations also will not work in a structurally obstructive lesion. That's what I want to say. Because everybody, we will have calls like what inotrope to be started. That is the reason I'm telling.
So identifying a critical congenital heart disease in emergency and starting prostaglandin, awaiting echo is the after stabilizing TABC is the life-saving measure that you can do as a pediatrician, right? How could you have prevented this? A baby crashing into your emergency, coming on day 11, day 12 of life with these symptoms when the baby was born, and could the hospital have done something to prevent it or to foresee this?
So we should do screening before discharge. Before
Okay.
discharging the baby.
It's a very important slide.
So, clinically, we should check pulsage of all 4 limbs before discharge, and we should go for pulse oximetry screening before discharging the baby.
Okay,
Just
so
that
what do you
slide.
see? What do you see in pulse oximetry screening? I think you have a.
So child so if it should be done at more than 24 hours of age or shortly before discharge. If baby is discharging before 24 hours of the age, we see saturation in preductal, that in right hand, and postductal in foot. If it is less than 90% on first screening, so we should go for further evaluation. And if it is between in preductal, it is 90 to 94%, and difference between preductal and postductal is more than 3%. We should repeat screening after 1 hour. And if again it is findings are similar, then we can repeat one more time. And if again same, then we should go for evaluation. And if saturation is more than equal to 95%, and the difference between preductal and postductal is less than 3%, the screen is passed.
Okay, we understand this. All the residents have seen. Can you explain the rationale of each and every point? First point, why should it be done after first 24 hours? Why not in the first 24 hours? Preferably, it should be done after 24 hours. If the baby is by chance getting discharged before 24 hours, then we do it. Otherwise, we prefer doing it after 24 hours, right? Why should it be done after 24 hours?
So because functional closure of PDA usually occurs after 12 to 24 hours. So if there is any obstructive lesion before that, PDA is giving systemic supplying systemic giving systemic circulation. So after 24 hours we should do because once PDA close, the presentation will be after that.
So in the first 24 hours, mostly babies have wet lungs. There is PPHN, and that PPHN also causes pre-postductal saturation difference, right? There is mild PPHN, there is wet lungs, even if the baby visibly may look normal. So you will have a lot of false positives. Many babies would end up having a a higher pre and post difference, but this will not be because of heart disease. This will just be because of PPHN. Generally, we wait for first 24 hours to let all of this settle. By chance, if the baby is getting discharged early, you would do it early, right? Then why not just the absolute value? Why do we also look at the difference, pre and post difference? Suppose the pre-ductal it's very common that you would ask the nurse ki sister, how much what were the values in CCHG screening? They would say sir, normal tha, normal tha. When you ask the values, they would say right upper limb is 100, lower limb is 96 or 95. On वैसे it looks normal, both the parameters are above 95, but is it normal?
No, sir.
Right?
Difference is more than 3%.
Difference is more than 3%, right? So you have to emphasize that they have to see the difference. So in which heart diseases you will see an exaggerated difference in upper limb, lower limb, differential cyanosis as they call it?
Just
So
go
in
one step back and then explain. Yes.
So in duct-dependent systemic circulation lesions, there'll be.
Yes, so if the duct is because the duct attaches on the aorta distal to the left subclavian artery. So in duct dependent systemic circulation, the lower limb will be supplied by the ductus, which will bring deoxygenated blood from the pulmonary artery, right? So yes, and even in PPHN, it will be the same, and duct dependent systemic circulation, it will be the same. That upper limb will be more as compared to lower limb, right? So both the parameters are important. Can you go to the previous slide again? So if the child just has an exaggerated difference in upper limb, lower limb, we straight away don't order an echo, right? We wait, repeat it after 1 hour. We repeat it after 1 hour. Why? Because even PPHN will cause the same thing, differential cyanosis, right? So maybe there is PPHN might settle in 1 hour. And maybe the child is in pain, child is in crying, having PAH, right? So we wait. However, if the absolute value NE is less than 90, we straight away go for echo. But for the difference thing, we just generally usually wait, right? So I would recommend all the fellows to go through this thoroughly. No baby should be discharged from our hospitals without a pulse oximetry screening. It is something which is non-negotiable in today's day and age. And all your nurses, all your colleagues should be aware of it. And it should be done after first 24 hours for all the babies, right? So it is something which, and in addition to pulse oximetry screening, all the babies should be examined for murmurs, and femorals and distal pulses should also be examined, right? Sir, if you like to add anything here.
Perfectly. I'm just listening. The discussion is happening in the right direction. But what I say here, the management regarding if anything challenging you, Dr. Preeti, can present, then I'll request Dr. Cardiologist, Pediatric Cardiologist, Dr. Bhargavi is there. So we came in PDA up to the medical management. But medical management, this baby luckily responded. But if not responding, as a neonatologist, we should know when to close it surgically. That's few slides I will request Dr. Bhargavi, if there is some procedure slides or some guidelines there to highlight. Like we doctor, the coarctation out also. I will say Dr. Prerna Bhatna, she is, if she has joined also, she can give inputs. about the coagulation or the PDA when we direct the pediatrician neonatologist to go for managing those babies surgically. Medically management, identification, I think we discussed at length. I will come few of the important questions the delegates asked last. I will come to that. Before that, I will request both of the pediatric cardiologists if any inputs specifically about surgical, because many times when surgery comes, we solely depends on the guidance of the cardiologist. Till the medical management, probably many of the units, point of care use, assessment, severity, and medical management will take control. When it comes to surgical management by device closure or by surgical ligation, many times we hold a discussion and as per the consensus we go for. So Dr. Bhargavi, do you have any guidance, any slides, anything?
Yes, sir. I'll show the slides. So two things I want to ask actually.
You can stop sharing.
I'm sharing.
And Dr. Preeti has to stop actually. Dr. Preeti has to stop, sir. Yeah.
Yes. Okay. Just able to see my systems. Sorry, very. It seems, sir.
Yeah. The system, the desktop, we can see.
Okay. So I want to ask two questions, sir. When we are giving the paracetamol, so how many days you want to give for a like this preterm PDA? So Prerna's case, sir, is it 3 days, 5 days? It's first for everybody, I'm asking.
No, it's the good question. With the pharmacotherapy part, we have not gone into detail. We were thinking we'll discuss few of the questions if there. But it comes to Brufen and comes to Ethasin, the dose duration is clear, and failing the second dose guidelines is clear. But coming to paracetamol, the second dose repeat extended course guideline is similar to Brufen and Domethacin. But I'll come to the duration of the primary dose, first dose. The dose started at consensus, no consensus, started the initial reporting in 2011, started with up to 7 days. Then many of the trials came down to 5 days, but the majority trials currently going on is with 3 days. But because 5 days, 7 days time, many people use 3 times daily. 10 milligram per kg also some people use, 7.5 milligram also some people use. But now the dosing pattern is 15 milligram per kg per dose. That is, there is a consensus. Now 6 hourly dose, there is a consensus. But dose using 3 days or 5 days for the primary, there's still confusion there. Probably one of the meta-analysis or some review of all the studies can guide us. But 6 hourly and 15 milligram per kg, now there is a consensus of those 2 points. Duration 3 days or 5 days. There is no consensus. Okay. Some people use 3 days and stop it. And if you're not closing, they go for second dose. And some people continue till 5 days. Then they decide, okay, now fails. Extended use of 3 days or 5 days, they use it. That's the current practice. Dr. Sankalp and Dr. Rohit, are you agree with my comments?
So, sir, normally
my duration comments, Dr. Sankalp.
Yeah, so normally in our unit, we are doing a check echo at 48 to 72 hours. And even if it is closed, then we are at present going for the 5-day regimen, because sometimes, early, some people do advocate that stopping PCM at 3 days leads to ductal reopening and re-symptoms. So I think it's a gray zone, 3 versus 5, but this needs to be addressed.
I think dose wise, sir, we all have clarity. 15 mg per kg per dose 6 hourly, but duration 3 to 5 days is all of us, which are following.
Yeah. Thank you, sir. Thank you for that one. So, like we have a hemodynamically significant PDA, 2 courses of paracetamol or paracetamol brufen, or 2 doses of paracetamol and brufen was went, but still we have pulmonary overcirculation and systemic hypoperfusion. That time I think we have to have a closure of the PDA. So it can be a surgical ligation, which is a very gold standard, or now what we are whole world is turning up towards is a device closure of a preterm PDA using a device called as Piccolo device. So surgical ligation is gold standard, but it has its own limitation, because when child is having bleeding disorders, thrombocytopenia, and again pneumothorax, So due to surgical ligation, there is a high risk of pneumothorax or recurrent laryngeal nerve injury or phrenic nerve causing diaphragmatic palsy. So here we can see this is a four-chamber view where the left heart is dilated, and the second picture shows huge PDA. So, and this is the red flow completely left to right shunt. So in these cases, this is a case neonate which received 2 courses of paracetamol, are now in the 3rd week with pulmonary overcirculation and systemic hypoperfusion. So here what we have done is, we have a device called as Piccolo. So this is the device. It comes in 3 varieties, 3 lengths, 2 mm, 4 mm and 6 mm length of various sizes. So we do an angiographic procedure. We'll take a femoral venous route. We'll go IVC, right atrium, right ventricle, pulmonary artery, and then the PDA. So my catheter tip, my arrow is there at the PDA and into descending aorta. So we have given an angiogram to delineate the PDA. So then what we will do is, we will go with a device, and this is the echocardiography, which we can see this arrow mark is the device. We are deploying the device in the aorta and we are pulling into the PDA, and then gradually we'll deploy the complete device in the PA. So whole PDA is obliterated by the device. So then post device, we will do an echo, and also angiogram we will not do because these are all small babies less than 1 kg. So most of the time we avoid angiogram. And this here we can show that both the pulmonary arteries are good size. Flows are now laminar in LPA, and this is the device which has closed completely the duct. So this is called as PDA device closure using Piccolo, but there are some contraindications in device closure also. That means if PDA, there is no restriction point. For example, Dr. Preeti told about the velocities. If velocities is more than 2, that is a good, means there is a restriction narrow point and we can go ahead with a device closure, or else surgical ligation is only better. So no active infection should be there, and there should not be any coarctation of aorta. When there is a coarctation of aorta, we should not close the PDA. So that means cardiac output is dependent on the PDA. So these are the things, contraindication points for PDA device closure. Till now, actually, these are 11 cases, but we have closed around 24 preterm PDA cases, range weight of 560 to 2 kilos babies. So 1.8 kg baby. And in that all, they extubated mostly around 48 to 72 hours post procedure. And here we will not have any pneumothorax and also hypertension. Systemic hypertension is the another thing when you do a PDA ligation, because over the PDA, the nerves fluxes and it causes systemic hypertension that will be delineated by the device closure, and child can be extubated early. NEC sepsis can be managed properly because PDA and sepsis goes hand in hand. When you treat PDA, then sepsis also will slowly come down because your pulmonary overcirculation is coming down. So actually Preeti has shown, these are the Doppler patterns of the PDA. So this is the first pattern, A pattern, where you have a right to left shunt. This is severe bidirectional shunting pattern. Here, don't close the PDA. Second is the pulsatile pattern, but your systolic diastolics are difference is more. Here, it needs hemodynamically significant PDA, and this needs therapy. And then there is a growing pattern of PDA where your velocities are less, but your systolic diastolic are also okay. So this type of pattern, it's like a transitional circulation, we can wait. So another is the completely closing pattern of the PDA. So these are the patterns of the PDA. So next one, regarding coarctation also. So we also have a similar case of day 7 with poor feeding, and pediatrician felt there is a gallop rhythm and sent to us. Actually, there is very important thing is fetal scans. If you have a fetal scan showing right heart dilatation, TIFA or growth scans, that means there is a high propensity of child is having a coarctation of aorta. So don't, like if TIFA shows dilated right heart, please examine the baby, and again femorals should be examined because they correlate with the coarctation of aorta most of the time. So heart tachypnea, gallop, low volume pulse. So this is the first panel showing biventricular dysfunction. Heart is not at all contracting. Here we can see the very less flow in the descending aorta, and the gradients will not come when you have a ventricular dysfunction. You may have coarctation severe, but your velocities at the coarctation part may not come because ventricle is not at all ejecting any blood. So we can do one is surgery, or else we can do a balloon dilatation at the as a palliative procedure. I will show. So this is the balloon. We went through right axillary root, crossed the coarctation segment, and then the balloon dilatation was done. Sorry, they are playing very fast. So this is actually the coarctation segment. It's like a palliation, but gold standard is the surgical repair. So absent femorals and subtle signs during your fetal scans like dilated right heart and ductus is main important in coarctation. So when you do surgery, this is a surgical picture which shows the thoracotomy from the side, left thoracotomy. This is the arrow where they have repaired the coarctation. That is the sutures actually. And I'm just showing for the students. So in this picture, it's a sternotomy. My arrow, this is a ascending aorta. We are seeing the arch branches. And you can see the diameter just narrowed from here to here. This is called as arch hypoplasia and coarctation. So we do complete repair of the arch and the coarctation segment. So long plasty will be there. Here, very important post management in NICU also, because the perfusion to the cerebral perfusion should be maintained during these type of surgeries of arch. Thank you. Sir.
Thank you. Thank you for guiding this. Specifically, people, we as a neonatologist, now we are aware the open ligation, open surgery thoracotomy ligation of PDA, we can avoid by the device closure. And if we understand the indication of device closure, whenever it is required, it is like medication, same principle applies. If it's not required, probably after assessment, we need not go for aggressive managing. If medication, then we are so conservative, why to go for surgery? So we should know the right indication, but when it required, early decision making on availability of the device closure, sometimes instead of the PDA ligation, might be helpful for the smaller babies. That's the overall message. And to all the trainees also should know how to optimize that. Therapy is available all over India, many of the centers doing, but how to early decision when to take, because same baby end into organ perfusion, organ failure, chronic lung disease. After 6 weeks, somebody deciding for a device closure might not be helpful, but too early taking call at 7 days or 10 days may not be very useful to the baby. Many times it closes after pharmacotherapy. So the choosing the right timing and right procedure is the important key message. Probably I will think all will try to, during the process of learning, we should use it. So thank you, Dr. Bhargavi, for showing all the, when we see something, the ideas comes clear actually to the student trainees also. When they do, then they see the parallelly what can happen in a medically managed case, how when an end into surgery. That we should understand clearly. With this, actually, I thank all the faculties. I will quickly request, because unless we take the questions, few of the important questions, we should not close it. That's the format, because the discussion went well. The PDA, all the aspects, I was eager to ask few more questions, but we moved to another disease here, coarctation of aorta, its identification, rescue, that Dr. Sankalp has quickly said. Rescue is more important, identification and rescue, rather than waiting for a critical heart disease, waiting for echocardiography. That's a very MCQ question also, OSCE question also. Among all the things he will do, prostaglandin or the 2D echo. The choice comes in prostaglandin. If you don't know the cause also, you start it, later you can evaluate. That's a very well highlighted here. All the aspects highlighted. I'll request if you can take questions, all faculty can see the questions. Any of the questions you would like to answer, you can take the questions. So I'll ask few of the questions from beginning. Either Dr. Rohit or Dr. Shankal, both can go for. Is milking contraindicated in less than 28 weeks or less than 32 weeks? That's a question from the audience. Is probably right, relevant question. because this year, the first NOEL session we opened with 2022 beyond the NRP corrections. What happened after 2021-22, the guideline, and beyond that till 2024, what corrections happened? That we presented in the session. So that's question discussed there, but please highlight it actually. They're asking. So audience should get a clarity. Any of you? What do you suggest the audience, 32 or 28?
So frankly, sir, I'm not aware of the exact cutoff, but practically less than 32 weeks, we don't do umbilical cord milking, but I'm not sure what the guidelines, what is the exact cutoff mentioned in the books.
Sir, I would go for
Books,
32
you are right only. 32 weeks, they perfectly right, 32 weeks. But current NRP guidelines says if a non-vigorous less than 28 weeker, even non-vigorous, you don't go for milking, even non-vigorous. Baby vigorous will go for delayed cord clamping, no confusion there. Less than 28 weeks, if non-vigorous, somebody will tempted to do a milking, don't do below 28 weeks. Previously, the guideline was 32 weeks. Now they extended down to 28 weeks. If 28 to 32 weeks, somebody non-vigorous in front of us, you give the option of milking, intact cord milking is the option to be given with the benefits rather than the harm. That's a new line added in the NRP correction 2024. So that somebody is asking probably specifically. The cutoff was 32. Now the cutoff is 28.
Okay.
So that's clarified things probably. Requirement of second dose of surfactant in detail we discussed. So then somebody is asking if we are doing a PDA neurosonogram, MC or ACA artery if we'll do, what exactly we want to see. I will request Dr. Bhargavi, the concept of resistive index and the relation of systolic and diastolic flow. If somebody is interested to know, one liner if you can guide. If I'm doing a neurosonogram in a baby of hemodynamically significant PDA, which parameter I would like to see?
So if we are doing a MC Dopplers, a neurosonogram in a PDA case, sometimes the MC Dopplers will be elevated. So those things we have to see.
So the RI, resistive index, normally we interpret resistive index. So resistive index is again a systolic velocity minus diastolic by systolic. So there is a change in diastolic, the negative component which is lower and lower. So the resistive index goes up and up. So that's the trend we see normally in more hemodynamic significantly. But the exact value, I'm not interested. I'm interested in the trend. If it's increasing RI from the previous status to the progressive status, we should observe that probably the PDA is becoming so significant that it is affected the cerebral circulation also. So that's a question, and interesting question. Anybody can take, very interesting question. How to pick the baby with coarctation aorta? The baby has shock where all pulses are absent or feeble. It's not absent, it will be feeble. So normally we say bilateral palpate the femoral, but all pulses are weak only. So how to identify? There's a question from the trainees. It may be a practical question.
Yeah,
so anybody want to take?
Severe biventricular dysfunction, yes, all the pulses will be feeble. So, but I think there will be a difference between upper limb, lower limb blood pressure and coarctation still. There will be murmur, gallop rhythm, cardiomegaly on X-ray. So all these pointers are pointers towards left side obstructive lesion. And if you have such scenario where which is fitting into this, one should consider starting, prostaglandins as we have discussed. So sorry.
Sorry. So most of the time when the baby of coarctation biventricular dysfunction comes, all peripheral pulses will be weak, absent also. But when you ventilate the child and airway is taken up, then you may have the pressure difference properly. So that's practically what we observe. Initially, it will be there. The all pulses will be feeble. But when you take out the ventilation, your pulmonary edema is settling, and then some cardiac output will be increased, then you can see the difference of the pulse. And gallop rhythm and all are definitely saturation difference, gallop rhythm, we should consider coarctation only.
Yeah, when these babies come crashed in the emergency, then all pulses are not palpable. But once you stabilize TABC, temperature, airway, breathing, circulation, then you would be able to appreciate these differences more.
Perfect. The message is perfect. One question only. I will like to take one question here. So the question they specifically asked, which is maybe relevant to all neonatologists. One time, a hemodynamically significant period treated, the 2D echo done like this presented case, it is closed. Now 4th week or 3rd week or 5th week, again it is reopened. It is becoming symptomatic. Just reopened may not be issue. symptomatic and reopened, how to proceed. Both of neonatologists, you can guide actually, maybe a common scenario with us. We are seeing those type of babies. So the question is, should we go for a second dose of pharmacotherapy or how to go for? That's the question actually.
I think first, most important is that if the PDA is reopened, make sure that it is HSPDA and the symptoms are due to the PDA. It may be just be an innocent bystander. So if the PDA is HSPDA, and quite often we see that there is PDA, but the baby is just on 21% FiO2, tolerating full feeds, growing well. In those babies, I would not want to treat PDA. So if the baby is symptomatic, if there are clinical symptoms of systemic hypoperfusion, pulmonary overload, and echocardiographically HSPDA, I would like to give a repeat course. And if Brufen is not contraindicated, it would be my first choice. If there is no contraindication to Brufen, we know the contraindications, platelet count, renal function, etc. It would be my first choice for such a baby.
And even we can use high
Really
dose
agree with
oral.
Rohit.
Even you can use oral Brufen because most likely after 15 to 20 days, baby has reached, most babies, they do reach on full feeds. So that is one another advantage with oral Brufen.
Perfectly. Though few things to add on actually. There's a feeding practice during PDA. There are a lot of controversies if active PDA you are treating. But PDA, I will say pass a message. If you are treating a hemodynamically significant PDA, you may not rapidly increase the feeding, but no guideline stops us from feeding. So a trophic feeding or a minimal feeding to be continued, even though we are treating a symptomatic PDA. But incremental during that active phase of symptom, increasing you may not opt for. That's the message I will say. That's all will agree. But repeatedly the question comes, how I will proceed with the feeding increment. Because third day baby, fourth day baby, I'm in incremental feeding, how we go for. Fluid restriction rule is same. If a failure state, cardiac dysfunction, choose the fluid wisely, little restriction. Otherwise, if you are saying no cardiac failure, no cardiac dysfunction, maybe adequate fluid management is more key. I'm saying respiratory stabilization, adequate fluid management. No, for every case of PDA, to restrict fluid is not the guideline. So few of the common general things I'm passing so that this practices will be, all people may be doing little different possible, but the guideline, when a guideline and consensus. So this is the way overall PDA things we are speaking. So any of the faculties, Dr. Sohana also there, the Sohana Gupta from New Clinic, she is also joined, she is putting some answers and messages. So she's saying late cases, treat the cause. Like treat the cause means I understand if anemia is there, treat anemia. Sepsis is there, treat sepsis. Rather than jumping into PDA the way, and so Dr. Sankalpa also told same thing. So with this management, all the thing, one message from all the faculties, you can pass, all three faculties, you can pass one message before closing the session. But before closing the session, I thank Dr. Preeti to present both the cases, cardiac cases, for a lot of learning for all the audience, including us. And the faculty of Neo Clinic, Dr. Rohit, Dr. Sohana, and the cardiologist, Dr. Bhatt, she all contributed the case management, so we could learn from them. So thank you them, and including both the faculties very actively participated. I thank that both the probably Dr. Sankalp I'm seeing on the screen first time, though I spoke before in telephonic, and Dr. Bhargavi, my colleague here in the Rainbow Children's Hospital, Hyderabad Cardiac Center. They're having one of the biggest pediatric cardiology center with all cardiothoracic surgery, ECMO facilities, everything. They're different unit, completely different building, but as a team we work here. But I saw them daily, how they work with how much passion for the early morning teaching for DN cardiology students, neonatologist teaching, and the work with such a huge workload. I've seen her, no need to tell more about her. But Dr. Sankal, throughout the session, your inputs are greatly appreciated by students. Dr. Rohit guiding the students for the presentation, such a short period, 2 cases at a time, and thoroughly covering through the presentation all aspects of PDA and coagulation is commendable. I appreciate all contributions for this NOEL teaching. But before closing, again, I'll request one message for the trainees and students. Please, from this session, whatever we thought it should pass to the student, please by one message or a 1-minute message, you can choose, and please let us know. So Dr. Bhargavi, before going to neonatologist.
Okay, sir. So thank you for the opportunity, sir. Dr. Preeti, well presented. Actually, 2 cases you have shown properly, over circulations and hypoperfusion and ductal dependent lesions. So I would say important points are not all PDAs require treatment. That is main crux of this one. So we have to see which are the hemodynamically significant causing issues. There only we have to go for the management. And as Sir told, the volume management is also very important. I don't want to dehydrate the child or decrease the weight. We have to maintain the weight and also like 2/3 maintenance to full maintenance. See the input output and then manage. And medical management is the first mode of therapy. So taking 2 doses of PCM, then we will assess, and correcting other factors, sepsis, anemia is very important. And I like Sankalp sir's main thing is in shock, you have no femorals and gallop rhythm, start prostaglandin. That sentence I liked very much because prostaglandin should be there in all NICU units, I would say. So whenever doubt, starting prostaglandin, even for example, PPHN child comes, starting a prostaglandin will help the child. It doesn't deteriorate the child because it opens up the PDA and RV overload will be decreased. So keeping a prostaglandin is the best message to all the units. Thank you, sir.
Perfect. Perfect learning. The pearls, today's 2 cases, 2 pearls for the students. So Dr. Sankalp.
First of all, thank you, sir, for the opportunity. It was a very nice interactive learning session for me too. So from the first case, I would like to congratulate Dr. Preeti. And for the first case, I think the learning is what we discussed. That we need not treat all the PDAs, and also the causes of secondary deterioration on second, third day, the way Dr. Preeti described in a very systematic way. Like think of a pneumothorax or tube displacement, second dose of surfactant being required, sepsis, PDA. So that scenario is quite common in daily practice, that you have a preterm baby with whom you give surfactant, and then day 3, day 4 again the baby has increased ventilatory requirements. So that those differentials I think were very nicely put and discussed. And from the second case, I think for one is prevention of early diagnosis of coarctation by clinical examination and pulse oximetry screening before discharge, and then approach to a baby who is coming crashing to your emergency and who likely has a left side obstructive lesion. So that I think we discussed, and that prostaglandin should be available with all of us at 24/7 in our NICUs. And if we have such a baby, we should start the injection awaiting an echocardiography. So I think those are the key messages that I would like all the residents to take, sir.
Thank you, Dr. Sankalp. Dr. Rohit, closing, actually, there's a lot of learning from your cases. So please.
So thank you so much, sir, for providing me this opportunity, and I thank all my co-faculty. It was really interactive, and many more concepts became clear. And I would just like to summarize: no routine screening of PDA and 100% pulse oximetry screening before discharge. So no for PDA and 100% as a keep it as your practice. All babies should be screened, undergo a pulse oximetry screening, and almost I think in my practice I'm detecting every year 1 or 2 cases by just this simple practice. That's the key message, I think, from my side.
Okay. So thank you all for all the inputs. And Preeti, I hope you presented well, but I hope you learned from this session.
Yes,
so these
sir.
2 cases, during the management also it taught us in the bedside, but during presentation, probably few of the aspects which is not probably opened up, but now during this discussion must be opened up to you. And the continuous learning process, I wish a continuous learning for you. It's not till examination until further also. That's why I can wish. Now closing the session, like two important lines, not for the disease or the pathology I'm speaking. I'm saying neonatologists like less is more. So unless required, as highlighted, unless required, don't do a routine screening up to DECO. And first 3 days, observe the baby, and if required, do it. That decreases the treatment. You do it to DECO, grade it, identify which the right candidate will get benefit from our treatment, treat there, reduce further treatment, how much required. And again, less is more. So duration, 3 days duration, baby responding, you can stop it. 5 days duration responding, stop it. Don't prolong just A protocol says to prolong, I will prolong. Response is there, think once again. So these are the less is more. Second, I will say many of the places the advice comes masterly inactivity, just observe. But for masterly inactivity, first be a master. Unless be your master, that cannot be applicable. So be a master means strengthen by knowledge and practice, strengthen yourself, identify the right problem, then probably you can wait. Otherwise, this coactation aorta, when there is no masterly inactivity, there is aggressive management, early identification is key here. So when this emergency situations, act early. You can diagnose later, but act early, save the life. So these are the few different situations, different scenarios we have to apply our philosophy. So that will help us in the lot of other case management also. With this, thanking all of you, I am closing the session. Next week, again, Thursday, we'll come back again with the cardiac case, and probably few of the faces of the faculties who will wait in future. The audience will see again with the contributions, though they are learning. So I hope that you will join later in the NOEL session again. Thank you all. Good night.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.